As you can imagine, there are a very high volume of callers as we have gathered folks from all 12 sites. So if you do have a question or a comment, which we very much want to take in all the questions or comments, if you could please use the chat feature within WebEx, and we will make sure that those are all addressed. We will have a designated scribe documenting all the questions and comments so that the folks who are not able to join us will be able to review those later. And I'm also recording this meeting. I started that a few moments ago. So folks will be able to, again, look at this later, or you yourself could refer back to it. If you are, for any reason, unable to use the WebEx chat feature, please feel free to email me. Again, this is Katie Martin. If you reply to the invite, I'm the one who sent it, so I will be able to get that email with any of your feedback. So with no further ado, our nursing sneak peek is going to be led by Megan Lawhon, so I will turn it over to her.
Thank you, Katie. I will start sharing my screen. And we can go ahead and get started with the nursing portion of our sneak peek. So today we will be covering the optimized admission workflow, and this includes an updated admission history power form as well as an admission workflow end page. We will then move into some other workflow end pages, which include a handoff, which is utilized for shift-to-shift handoff or handoff from a patient transferring from one unit to another, as well as the discharge end page, and then we will land on the clinical leader organizer, which is another tool to use for viewing all of your patients and the information in one view. So as you all can see on my screen, we are at Care Compass. So not much will change with Care Compass. I'm sure you all are familiar with navigating through your patients in your day utilizing Care Compass. We did just want to start with the admission history power form, which we are optimizing and uplifting with this effort. So we will start by documenting on the task from Care Compass. So this is the optimized and updated admission history power form. As you can see, it's been condensed quite a bit from what you all are used to documenting on today within this power form. This form has been evaluated using practice-based evidence to arrive at an essential clinical data set for nursing to document the admission history. We really want to minimize the admission documentation to allow you as a nurse to spend more time actually caring for your patients. So we start with our general information, which has been condensed a little bit, but familiar with what you all have today. Our patient today, we will have a chief complaint as a persistent cough and sore throat. Information given by, we have some other information such as sensory deficits, child care, guardianship documents, and emergency contact information that can all be populated within the form. Your advanced directive section is also slimmed down quite a bit. So you have your advanced directive, yes or no, and then any additional information. You then can document the patient preferred language, interpreter information, or caregiver information. Next is your infectious disease and vaccination history. So you have the infectious history as well as any exposure due to recent travel. And we can document family member travel history as well, and then any exposure symptoms. Moving on into your pneumonia screening, it's offered year-round, right, so you have your documentation. So we can document any necessary fields to complete that section. Moving on into our nutritional risk factors, you can document those risk factors, any home diet information, and then our malnutrition screening tool. Social history is a big update for you all with this optimization effort. So social history will be within this power form as a social history control. This will flow into the workflow end pages that can be viewed within that histories component, which we'll get to here in a minute, as well as the histories within your table of contents. So you can document your social history directly within this control. This red asterisk designates that the category is mandatory. So we have tobacco as a mandatory field to be documented. Clicking the Add icon will allow you to document your information for the applicable category. So here we have our tobacco use. We'll say that our patient is an everyday smoker. We can get into the type, tobacco use per day, concerns about tobacco use in the household, any further information you'd like to document based on tobacco. You can then see by documenting that tobacco information that the red asterisk has been removed and that has been completed. The other categories are not required, but certainly available for you to document if applicable. So we can go into our alcohol history, the different type and the frequency, average drinks per episode, maximum drinks, the age they started and stopped at, any previous treatment, if it's interfered with home life, drinking more than intended, anyone at risk, ready for change, concerns about alcohol in the household. Sorry, let me do that really quick. We then have our substance use information as well. This includes whether it's been current or past, the type of substance use, frequency, previous treatment, similar to the alcohol questions that we saw previously. We also have our sexual history information, whether the patient is sexually active, any current partners, lifetime partners, sexual orientation, and gender identity. Moving into our nutrition and health, so we can see any diet description information, the type of diet the patient is on, any caffeine intake, diet restrictions, supplements, desire to lose weight, etc. Home environment as well, whether they live alone or with any other family members, their marital status. You can enter spouse name, guardian information, sibling, and any living situation, home equipment, alcohol abuse, smoker, any of that information specific to home and environment. Our last three sections are employment and school, so just information around their employment or whether they are in school currently. Description of that, the activity level, highest education, school concerns. Moving into psychosocial, any fears or worries, how they deal with their fear. And then lastly, we have our exercise, which includes how frequently active they are, the type of exercise, physical activity. And with that, we should be able to complete our social history. And then the last section of the admission history power form is the Columbia Suicide Severity Rating Scale. So this is the CSSR suicide risk documentation that you will go through each question related to suicide. So upon completion of your form, you will sign your power form, and we will then navigate into our patient, Sam Smith, today. And this populates our nurse view. So this is a new workflow M-Page viewpoint that you all will be receiving, and the new functionality for your M-Pages will be in this workflow format. This admission workflow specific M-Page pulls together all the components of the admission intake process and allows you as a nurse to quickly document your admission history. This first component here, we can see the admission documentation pulls in information that we just documented on our admission history power form. You can easily view those results within the component. You can also drop down with the right-hand arrow and select the power form from this view as well. You can see all of that information that you previously documented for the admission history power form. Next, we have our allergies. So you're able to view, reconcile, and document any new allergies. So we can see that there is a previously documented allergy for latex. You're also able to add an allergy if the patient states this during your admission intake. We can add an allergy here. This allows you to add the severity, status. Those are the two required fields for the allergy. onset date, source, etc., and save that here. That will then populate into your allergies component so you can see what you just added for the penicillin allergy. Moving into home medications. This allows you to document and see any medications that the patient reports they were taking prior to admission, as well as add any medications that the patient is reporting if not listed. Next, we have our immunizations component. So this is a personalized schedule for the patient, and it shows any due or overdue immunizations for your patient. You're also able to document immunization history. Within the drop-down, we have the document history. And you're able to select any immunization to add to the component. Next, we have our history. So this will display any procedure, family, and social history. From that social history that we documented in the Power Form, we can see that that populates into our workflow MPage component. We can also navigate into our Histories tab by clicking the History link, which takes us into our histories on the table of contents. And we can see that social history information that flows there as well. By clicking the Home button, that will take you back to your nurse view where you left off. And our last component on the workflow admission history MPage is the problem list. So here you're able to see any documentation that exists for their problems, as well as add any chronic problems for the patient as they report those. One thing to note before we do move on into the handoff and other MPages within the component or within the nurse view component is that you are able to customize the different components. You can drag and drop on the left-hand side to say that you would rather see allergies display or home medications above the admission documentation. You're able to drag and drop, and those will move accordingly within your view. You can also come over here to the right-hand side with this drop-down. You can choose components, and this shows you all of the different components available within the MPage. You can choose to have a component on view or off view by clicking on that specific component. The check mark designates that the component will be displayed on view, and if off view, that will take the component off view. And then you can see you no longer have that allergies component there. These settings will save when you log out and log back in, so it's a one-time thing, but you can always modify those as necessary based on your patient and what information you would like to see. So now your admission history is complete by doing your admission history Power Form and fulfilling the admission components within the workflow MPage. We will then move on into the nurse handoff. So this view is designed to aid you in facilitating and documenting a patient handoff. It supports a continuous record by bringing in some essential information forward, regardless of whether you're an ED nurse or a floor nurse. You're able to be presented with one standardized view to help support your patient handoff. So we will go through each of the different components on here and note that some of the components do carry over from the various MPages just based on whether they're admission, handoff, or discharge specific and whether you want to see that information. So there are a few, such as allergies, that we saw in the admission, and those will flow over across the various MPages. So first we have our risk indicators component. So this allows you to view risk levels associated with data that is collected for a patient. The information that you will see here will be your fall risk information. So we see a fall risk score has been populated, as well as skin risk. So Britian score will populate in this component as well. Your chief complaint, so this pulls in from the chief complaint that we documented, so you're able to see that here within your handoff. Our actions and situational awareness. I think there's a little bit of background noise, some light music.
I'm going to try to find them, Megan.
Okay.
We hear your background music.
Just 1 second, Megan, until I find them.
You're good.
What an idiot.
Okay, I think we're good. Thank you. All right, so we have our actions and situational awareness component. This allows you to view, add or modify or delete any applicable actions or to-do items, as well as situational awareness remarks or comments for your patient or encounter. So an example of an action could be that your patient likes to have the pillow a certain way to support their neck. You're able to then save that, and any care team member that cares for this patient will see this information. An example of a situational awareness remark could be a family concern, like the patient gets upset when one of their family members enters the room. One thing to note is that these are not considered part of the patient's chart, but more so just information to hand off and allow other care team members to view. That way they know moving forward how they can better serve their patient and their needs. We have our problem list. So this again was on our admission end page, but anything documented between either of these end pages will flow over. Our lines, tubes, and drains component, this is intended to give you guys a comprehensive view of any invasive lines, tubes, drains, whether they're active or discontinued, that a patient receives over the course of their hospital stay. You're able to view more information by clicking on any of the lines, tubes, or drains that are populated and see any information that was documented specific to that line, tube, or drain. Any discontinued lines, tubes, or drains will display in the discontinued section of the component. This will only display if a dynamic group isn't activated within iView. One thing that I do want to note before we move on into the rest of the components is that some of the documentation you all use today, such as urinary catheters, some of your airway information, will be moving towards a dynamic group format. That way it's able to flow into the CLO appropriately, as well as more consistency with your documentation. So really quickly, we will navigate into our iView. So clicking on the link, header link will bring you into your iView. Navigating into our tubes and drains, there are a few pieces of documentation that have moved to a dynamic group. So urinary catheter information, just to give you a preview, has been updated. So we'll document the site and the size of the urinary catheter. And we're then able to document any further information specific to our urinary catheter.
No, I think it's honestly on us.
So upon signing that documentation, we should be able to see that flow into our lines, tubes, and drains.
All right, so this is,
if we refresh our M page and into our lines, tubes, and drains, we will see any new information that has been entered through the dynamic group into your lines, tubes, and drains component. Next, we have the intake and output. This will include any daily weight, fluid balance, or intake and output volume results since admission for the selected encounter, so we can see any different values, whether it be intake or output, and the date that occurred. Allergies, again, similar to the component that we saw within admission, so you're able to view, add, modify any of the allergies within this component. The orders will display any orders currently on the patient, so this acts similar to your orders tab within the table of contents. You can also launch into the orders tab from the workflow end page if you want to document through there. Labs will also show within the labs component, so any of the labs that have been done for the patient, as well as the date and time those have been documented. Similar with vital signs, we're able to see all the different vital signs and that trending information with the up and down arrows, similar to what you would see in iView, but just flowing into this end page to easily view during handoff. Imaging will pull in any diagnostic orders for the patient. So we see that this patient has an XR chest view ordered, the reason for exam, pneumonia, and the status. Quality measures also pulls in any quality measure information. Discharge planning will pull in information specific to discharge that has been, or typically will be completed throughout the patient's stay and available to you here through this component just to keep track of. We also have a discharge planning component in the discharge tab, which we'll get to here in a minute. We're able to see the anticipated discharge date, discharge to anticipated, home treatments, etc. Next, we have our handoff documentation. So this is information specific to handoff. You're able to launch into iView to document this documentation if it hasn't been documented already, or to view this. So this brings you into your iView, and you have various sections to complete the nursing shift handoff, transport and transfer information, and this will flow into our component. Having it here in the one component makes it easy to give that shift-to-shift handoff. We have our medications displayed within the handoff as well, so you can easily see any medications that the patient has been given during their stay. Next, we have any documents that have been completed for the patient, and then any scales and assessments, miscellaneous, that you are able to view within this component as well. Before we move into discharge, I do want to highlight the flagged events component. So this will pull any flagged annotations within iView. So if we navigate into our iView documentation and say that we want to flag a comment, we can flag a specific piece of documentation or the entire section in order to give the next caregiver or the next nurse coming in any further information based on our shift handoff. So we'll just do a quick testing comment, that way you can see how it flows over into our flagged events. Just refresh your workflow end page, and then you can see any additional comments that have been flagged. That way you have visibility to it within this one view. Okay, then we will move into our discharge end page. So this is a workflow end page designed to aid you in facilitating and documenting a patient discharge. This view does replace your previously used discharge summary. It allows you to review, update, and document information specific to departure, and it also flows between some of the physician components that the physician is responsible for, and you're able to see whether that has been completed and documented in your end page view. So again, we have our discharge planning component. So this shows any information related to that discharge planning assessment. We're also able to navigate to the power form where information can be documented. If anything has been documented, though, you will see it display here within your component. Again, we have the problem list that carries over throughout the patient's stay. Any follow-up information that the physician has recorded will display within your view, so you can see that follow-up has been complete, or instructions have been entered and completed. You can see that the green check mark indicates that a component is required, and if it's green, that means it has been completed. If it is a red asterisk, that means it needs to be completed before you can move on and discharge the patient successfully or appropriately. Discharge documentation pulls in any information from your discharge summary, so information that you've completed based on discharge for your patient. So we have the drop-down power forms and the drop-down menu. This takes you to your discharge summary power form where you will document that information and then see it flow into your discharge documentation. We have any home medications that the patient will want to either that they have recorded previously or will be taking on once they've been discharged. You can see that information here. IV stop times. This is specific to any IVs that are currently being received by your patient. So you would want these to be discontinued before discharging the patient. We see that the green check mark indicates that there are no outstanding IVs to be discontinued. If there are any, they will be displayed here, letting you know that those should be discontinued before discharge. order profile is similar to the orders component that we saw on the handoff, just showing you any orders remaining, outstanding orders, or any of those that still need to be completed. Quality measures and documents we also saw on the other components. They just flow over into this end page as well, so that you're able to easily see that information. And then lastly, we have our patient education. And this allows you to search for and select education materials or medication leaflets for a patient and print the added items with a customized cover sheet. So based on the problems, you can get some suggested education based on that problem and add that to your education to be printed for the patient. So then when you are ready to discharge, you can create your patient D-part summary. This pulls in the facility information, any inpatient discharge instructions from the provider, and this comes from that physician discharge workflow and flows into the note. So you see your inpatient discharge instructions, the discharge orders, provider information, reason for visit and diagnosis, any instructions from your doctor, scheduled follow-up appointments, medication instructions, any new medications as of the day that they were prescribed, various lab results if applicable, or immunizations, screenings, allergies, devices, and then you have your education materials based on what you populated in the component. And from there, you can sign and submit. In order to discharge your patient. So this will be slightly different in that you do not have the depart icon or door to depart your patient. It will all be done within this discharge workflow end page, allowing you to go through each component to complete that discharge and then create your note. Again, with any of these end pages, you're able to drag and drop the components to rearrange them to your liking or what makes most sense for your workflow, as well as take any components on or off view. So now we will move into the clinical leader organizer. So this is new functionality that you will be receiving here in October, and it provides a view for leaders to understand performance against goals and objectives. It provides progressive patient information while guarding against the potential risks to the patient. It is an interactive organizer that allows to support communication and coordination across the continuum of care. So here we have our viewpoint. All of the nursing positions will have access to the clinical leader organizer as their second tab within their default organizer. The nurse manager or supervisor roles will have it as their default view when they log into PowerChart. That will be the landing page. However, nursing does have access to view the same view. You have the ability to pull in a patient list. So similar to Care Compass or a patient list that you're familiar with today, you're able to pull in any of your active lists here, as well as go into your list maintenance to bring over any active lists or create a new list. You can also establish relationships with the patients on your list that may not have a relationship established. Here we see that both of these have been established, so that icon is dithered. So we can see information through the various columns on CLO or CLO. You might hear that referred to instead of clinical leader organizer. You have the location of your patient as well as the patient information, so the patient name, demographics, MRN, and FIN. We have our care team, so this will pull the attending provider within the display. You also have your visit information, so the length of stay, the admit date, and then the anticipated discharge date. And then just to highlight a few columns that we have on the clinical leader organizer that will populate, we have diet. There are various icons, as you can see, for diets, and based on the diet order that is placed, it will provide a different icon. By clicking on an icon, you're able to see further information for that diet. So here we can see that there are multiple diets placed on the patient. We just wanted to show you how that looks with multiple diets placed. Here we have a different icon just for that regular diet. We have a fall risk column, so this will show the fall risk score and whether it has increased or decreased since the last documentation. So opening up our fall risk, we can see that when it was first documented, it was a risk of, or a score of 75 down to 35, and we can see that trending arrow. Skin integrity will pull in your Braden score. Again, clicking on that will give you further information as to when it was assessed and who it was documented by. Pain works similarly. There are various pain scales that will pull into this component, so you're able to see the pain score for your patient. Next, we have our airway columns. This will pull in any airway documentation, so endotracheal tubes, pharyngeal airways, and tracheostomy tubes can be displayed here. We can see the type of tube, the activity, when it was assessed, and who it was documented by. We have a catheter column to pull in urinary catheter information. So this pulls in the type of catheter as well as the activity assessed and documented by. For this column specifically, we have an overdue functionality that will give this red triangle icon letting you know that the catheter needs to be reassessed. So it will show you that in red, this should be assessed as it has been in the patient past that overdue time. There is a suicide precautions column which will pull in if an order has been placed for suicide precautions for your patient, as well as an elopement column similarly to pull in that elopement precautions. Isolation will also pull in any isolation precautions that have been ordered. In the display, you can see that there are airborne precautions specific for this patient and when that was ordered. Upon a discharge order being placed, that will populate the discharge column, so we can see that there is a discharge patient order placed for the patient, letting you know that they are ready to be discharged. Restraints will pull in any restraint information for your patient, so whether that be nonviolent, violent, et cetera, that will pull into your restraints column. We also have high risk, so this will pull in any aspiration precautions, seizure precautions, various high risk indicators will pull into this with the hazard icon. Central line documentation can also pull in as a column on the clinical leader organizer, so we can see our line insertion and when that was documented. We have our opioid sedation score as a column as well for you to view. Getting into our last view, we have a ventilator column showing you that ventilator mode, when it was assessed and who it was documented by, as well as resuscitation status, showing you the status of that resuscitation order. One thing to note with the CELO is that it does not automatically refresh. So we can see that 5 minutes ago, we would not have seen any further information populate if it were to have been populated within or documented within that 5 minutes. So refreshing your CELO, you will see anything new that might have been documented for your patient and view that within the various columns. You are also able to launch into the patient's chart by clicking on the patient name, and that will take you into your nurse view where you can work through your workflow web pages. And then one last thing before we can open it up for some questions. We did clean up some of the table of contents, so we've rearranged putting the nurse view as your first tab, viewing all of your M pages specific to your patient documentation, as well as reorganize some of the most commonly or most utilized different tabs, so your orders, iView, task list, et cetera, and then everything else alphabetized at the bottom. And you can navigate to most of these tabs based on the component by either launching into the link or through the add functionality or drop-down functionality on various components. Well, with that, we can open it up to some questions. Katie, how do you want to go about doing that?
Yeah, I have those documented, and thank you so much, Megan. And I do have all the questions that came in over the WebEx or email, so we will run through those. Again, the Danielle Van, who is another one of our team members, is going to be documenting everything. So following the call, I will send out obviously this list of questions and comments as well as the recording link. So our first question is from Janice Ratka. And her question said, or her statement was that the communication fields do not meet the requirements for indicating if there is a designated decision maker. Where do we document this? Megan, are you still there?
I was on mute, sorry. All right, so that will be within our admission documentation, and that was that the communication section? So here we do have.
Yes, she was asking about the communication field.
Yep, so within our form here, we just have the preferred language, the interpreter, and the caregiver. And sorry, Katie, what was the specific piece that was missing?
She said these fields do not meet the requirements for indicating if there is a designated decision maker and where that should be documented.
Okay, I will have to take that as a follow-up. We did review this as a larger group to determine what information was pertinent for the admission history, so I will see if that is something that might need to be reevaluated or whether that's documented elsewhere.
Okay, great. We'll move into the next one then. This is another question from Janice Ratka. She said, why would the general information and Columbia screen not be required?
So there would need to be a certain question within each section to make that required. That is something that we can revisit to see if there is one in particular to make it required. So as of right now in the current design, there is not a requirement on those sections, so we can take that back to review.
Okay, Teresa Eskew asked, or stated that under the general information, pregnancy status was showing male not applicable.
So
or that it only shows that.
Yeah, so this will be flexed based on the gender of the patient. So with this patient being male, it already defaults to not applicable.
Thank you. Okay, the next question from Janice Ratka. Could you please explain the complete reconciliation button on orders?
Let me navigate to that. Oh, am I in the right spot? I might need some more clarification as to which component that was on. I can look at discharge.
Janice, are you there? Could you be able to provide some more?
Yeah, I was just typing it in. I could be wrong about what screen it was on. It was a red button that said reconciliation had not been completed, and it said complete reconciliation. But we were moving through screens so quickly, it's hard for me to say where exactly it was. I typed the question right when I saw it. So I think we were around, maybe it's on home medications. I don't think this is where we were, though. I don't think it was on admission.
I think it was in the handoff.
It was in the handoff? Is that where it was?
Possibly.
So I know that allergies will have the complete reconciliation
there it is.
ability.
But the one that I saw, it was red.
Red, okay.
Mm-hmm.
Megan, do we want to take that one and follow up and see if we can?
Yeah, we can
kind of slice out what that is. Okay, we'll take that one down, Janice.
Thank you.
Thank you.
Our next one is from Jeremy Ferris. Will the IV stop times include blood administration?
I will have to see what exactly pulls into the IV. Let me just see if I can look at that really quick. I know that it pulls in any IV medication, so I'll need to look specifically at what that filter is pulling at or pulling in and looking at to determine what exactly will populate that.
Okay. Thank you. We'll continue to collect all that information together into this document. Our next question is from Janice Recca. How are required items determined on the discharge end page?
So this was reviewed pretty heavily looking at what was currently required on your process today, as well as further conversations that were had around whether they should be required or not. So those conversations were previously discussed. There is, I think, room for modifications if it needs to be modified. There are certain components that have the ability to be required and not required. So there is that restraint on some of those, as well as just some conversations that were had as to whether there should be a requirement there or not.
So again, we're always worried about meeting regulatory requirements, and most of this stuff is required. It just is misleading to the nurses when we have some things marked as required and other things not. They think they don't have to do that. So like home medications, we would have to do that always. But IV stop times, if they're not on an IV, why would we have that?
So the IV stop times will only have the red asterisk if there is a IV currently documented or on the patient. So that one is just letting you know if there's anything that needs to be discontinued. I will have to look into home medications and whether we're able to make that required or not. As I mentioned, there are some of the components that we have constraints on to whether we can make those required or not. So I can look into home medications specifically. Are there any other ones in particular?
I would have to go through it more closely. I'm not sure. What is all on the discharge planning, for example? We have to have the follow-up appointment, and you've got that.
Yep, so this will pull in anything from the discharge planning assessment power form.
Okay, so things like where they're going, discharge to where, that's a requirement. We have to do that. Can you think of other things, Dana?
Megan, we probably need to take this offline.
We need to take this offline and
from nursing.
Yeah, talk
as a whole.
Yeah, talk to nursing leadership. Correct.
Okay.
Okay. Thank you. And the next question is from Janice. What if you are not discontinuing the IV medication, such as in the case of the patient transferring to another facility?
I want to say that there should be an override reason if it is required and there is a reason why it should not be discontinued. I can look at the component filters for what we have configured, but I do know that for any component that is able to be required, we are able to put an override reason in there if applicable.
Okay. Next question is from Janice Rack as well. Is there a functional pain scale available?
I guess, what do you mean by functional pain scale? As a component on an M page or just the documentation?
The documentation. You got to where we could see the pain, and one of the requirements for TJC is that we assess pain with a functional pain scale. In our current version of Cerner, we don't have that option.
Okay, so I do know that pain is being uplifted as a voice of the customer request, and so we do have that within our IVU documentation. So we have the new uplifted pain assessment and still going under validation within the mock domain to make sure that everything is built appropriately and what they were expecting, but we do have the new pain scales that can be documented within IVU. Is this what you're referring to? Because if so, I can kind of go through some of these.
Yes, yes.
Okay, perfect. So we can see if pain is present or not. The high-risk opioid.
Excellent. That's one of my other questions. So when you get to that one, you can skip it. That's great.
Okay. Perfect. We have whether they're able to self-report pain, and if so, this opens up various questions as to whether they're able to respond to the current year, the current month, current time, count backwards, reverse, and this will then populate your OMC score for concentration. Next, we have the CPOT scale, so if you're unable to self-report pain, if it's a patient that's non-ventilated or ventilated, that will open up different scoring. So we have our facial expressions, body movements, vocalization, and muscle tension, which will then populate that non-ventilated score. If you choose patient ventilated, that will then open up responses to accumulate into that ventilated score. We also have the FLAC and pain aid scales. So if you're unable to self-report pain, and we have 18 years or older and then 65 years or older, that will open up the appropriate scales. So we have our FLAC assessment going through face, legs, activity, cry, and consolability will give you that FLAC score. If you choose the pain aid score, that will open up, again, different documentation to populate that pain aid score.
What about for the self-report?
Self-reports, let me get down there. So you have your numeric and faces. That again will open up the appropriate scale and documentation appropriate for the scale.
Okay,
faces will open up the faces documentation.
Okay, so if you could just put that on your list of things, the TJC requirement is a functional pain scale.
Okay.
Okay, and Janice did have those other questions asking if there is an opioid risk assessment and where the opioid sedation score is documented. Have both of those been covered appropriately, Janice?
The other one I'll look at it. I'll find it. That's fine.
This is Dana. I asked about where the sedation score is documented.
So we have a pain sedation assessment section within iView.
Look, it's Passero. Yay!
Yep.
The crowd goes wild. Okay. Let's see. Janice had asked, what causes the restraint icon to populate? Is it only orders, or does nursing documentation also trigger it?
Sorry, I was on mute again. It is just orders. So there's a handful or any of the restraint orders will populate the icon on the clinical leader organizer.
Okay. Teresa Eskew asks if the discharge is able to be completed and printed if the provider does not complete their discharge criteria.
That might be a follow-up. I know, like I said, there are some override reasons that you're able to provide, but as to which components that is configured on, I would have to double check. So I'll take that as a follow-up just so I don't give you the wrong answer.
Okay. Jeremy Ferris asked if there are any changes to Care Compass.
For Care Compass, there are only some slight changes, such as your quick links. So previously you had some of your summary M pages that you're using today that will be replaced by the nurse view, will be able to be launched out to that nurse view instead of the M pages that no longer will exist on your table of contents. That really should be one of the only changes that is made. Everything else should be pretty consistent with what you see today.
Okay. Sabrina asked if there are new nursing care plans.
I would have to defer to another Cerner resource for that. I know that there is some work underway, but I do not have details specific to that.
And we can take that in follow-up. I know we have further sessions we have the integrated session, other sessions are coming up, and so we can potentially hit that question there as well. Dana Espinoza had asked if the nurses answer yes to the advanced directive, do other fields open?
Okay, so going back into the form, there was the one question that opened. Let me just navigate there. So by answering yes, that will then open up the additional information. So if we say no, we see that that is dithered out and unable to be documented since there is no advance directive. But if there is, then that will open up the additional information, yes or no.
Next, Colleen asks if the title of the discharge instruction page, quote, inpatient discharge instructions, she wanted to know if that shows for all admission statuses such as observational patients, because they have had a case of a patient challenging billing because of what was written on that discharge instruction sheet.
I will also have to take that as a follow-up. I know that there's a lot of customization and tokens behind the scenes for the discharge instructions, so depending on what that's looking at, that's what will populate the information, so I'll have to look at what exactly is pulling from there.
Okay. Next, Lois Marchand asked about documentation of functional capacity.
Actually, I made a mistake, and I'm really asking about the clinical frailty scale.
Oh, I see. Okay.
Sorry, which scale?
The clinical frailty scale.
I will have to also note that as a follow-up, just to get more information around that.
It talks about the activity of people and, whether they're very fit, it's the scale that measure their, how they can function.
Are you referring to, like, activities of daily living?
Yes.
So that will be documented. Okay, so that is in your iView, still within your ADL and safety restraints iView band, and once that loads, you have your ADLs to document as well as fall risk and various risk assessments. And safety is there as well. Is that what you're referring to?
Well, I was thinking something a little bit more detailed, but I guess that, that would work. That could work. Thank you.
Yep.
Okay, and Zandra Perez had asked a question about minors or folks that are under 18, but I'm not sure if that was in regards to a specific area of the documentation.
The pain scale options, it looked like it was asked if they were over 18, or did maybe I misread it wrong because it went a little quickly.
Sure. So there is one scale, and I'll have to find where it was. It was 18 and, sorry, let me find it before I say that. It was 18 and there was a 65 option. So let me see.
Yeah, I thought they both read over, so I wasn't sure if I was reading it right or.
So yeah, this is 18 years or older and then 65 years or older. There is a pediatric and neonatal pain assessment that will be different, and that will be found in your neonate or NICU and pediatric iView bands.
But what I meant is, what if they're not NICU or neonate and they're under 18? Like
that would, I would think, fall into the pediatric scale.
Okay.
Okay, and I just took a quick look at my email as well as the WebEx, and I did not see any additional questions. Was there anything else that we wanted to touch on? Again, we will collate all of those questions and responses for the record. All right, well, in that case, thank you all for joining. Thank you, Megan, for your presentation, and we will distribute this information soon, and we're looking forward to our testing event next week. Thank you.